I'm Jim Friedman. I'm the Executive Director of the American Academy of HIV Medicine. I want to welcome you all. I'm pleased to see you here today. I do want to note that we are videotaping this session, and it will be available on our website starting early next week, I hope. This forum is directed at the HIV practitioner who's on the front lines of delivering HIV care. Over the last couple of years, several significant policy changes and initiatives, most importantly, the Affordable Care Act, have set in motion a lot of changes that will impact your practices. And we think it's important that those policy changes are translated into things that are meaningful for the practitioner, so he or she can get involved in the activities at the state and local level and adapt his or her practice to facilitate all of that. And today we have gathered together a stellar group of senior federal officials and policy experts who will help translate those policy issues into information that you can use in your practices. They will provide some insights and some clarity in what is to come into your practices in the next couple of years. It is my honor to introduce the moderator for today's session, Mr. Richard Sorian. Most recently, Mr. Sorian served as the Assistant Secretary for Public Affairs in the Department of Health and Human Services, helping President Obama and Secretary Sebelius in communicating to the American public about health care. While Mr. Sorian has held a number of very important policy and communications positions in and out of government over his career, the ones that are held most important to me, and I think to a number of others perhaps in this audience who are doing health policy in Washington, D.C. in the 80s and 90s. He was the editor of Health Legislation and Regulation from 1980 to 85 and from 1985 to 93, Medicine and Health. These were newsletters, came out weekly, that told us in government, and I suspect others in health policy, what was really going on in health. And he was the guy that was the editor for all of that. So we're really pleased to have him here as the moderator. Again, it is my privilege to introduce Mr. Richard Sorian. Thank you.
Thanks, Jim, and thank you for including me today. Early in your career, you pad out your resume so that it doesn't look like you just started last week, and I'm now at that stage in my career where I have to start cutting things back. So I actually worked when there was only paper and nothing was online, and every once a week was enough time for people to know what was happening in Washington. So you can see how much things have changed. But one of the things that I was proudest of was some of the earliest reporting on the epidemic before it even had a name, and when it had some really bad names early on. And that work does continue, and I want to welcome you here, but also welcome you back to the International AIDS Conference in the United States. It's been a very, very long time since we've had the ability and the honor to have this conference in our country and in our city, so I hope you are enjoying the time here. We actually managed to get the temperature down for a day or two, but don't depend on that. It'll go back up very soon. We have a very exciting afternoon planned with a lot of really key experts on healthcare policy, and in particular on HIV/AIDS and the delivery of care to patients. So I just thought it would be useful to set the context a little bit before we dive into the specific issues. You can imagine, as we were preparing for this conference a few weeks ago, there were some rather big unanswered questions. The fate of the Patient Protection and Affordable Care Act was hanging really, in some ways, we didn't realize how thin a thread it was hanging by until the final decision by the Supreme Court. But we were trying to think, well, if the Affordable Care Act is overturned before the conference begins, we're going to have to do a lot of work to try to rework the whole agenda. But for many, many reasons, that one the least of which, I personally was extraordinarily pleased and really just almost ecstatic that the law was upheld. But there is so much work to be done and so much more that we need to understand before we can actually implement an historic law like that. Let me talk a little bit about some of the major provisions, just so that it provides, as I said, some context for the conversations to come. The Affordable Care Act attempts to tackle some of our bigger problems in healthcare, and it does so first and probably the most important of which is to try to dramatically reduce the number of uninsured people in the United States. I have had the honor occasionally to either meet with international delegations from developing countries, from fully developed countries, and all the kinds of countries in between. And I have to tell you that whenever I explain that in my country about 15 to 20% of our population has no health insurance. I remember looking at a group of Turkish government accountants who had come to study the U.S. healthcare system, and they looked at me, and through their translator they said, "Did you really say that there are 50 million uninsured people in your country?" And I said, "Yes." They said, "Well, in Turkey we all have health insurance." And I said, "Well, in almost all other countries we do." Well, the Affordable Care Act won't make every American eligible for insurance, but about 2/3 of the 50 million people who are currently uninsured, or about 30 to 35 million people, will gain access to health insurance that they don't have access to today. Second, it invests heavily in public health and prevention, two issues that are dear to all of us in this room and to the people that we work with and the patients that you serve. Rather historic investments in both public health and in prevention, really putting prevention higher on the agenda of healthcare. It's always been sort of the stepchild in many cases, particularly as the government looks at it. And then third, trying to bring down the rate of inflation in healthcare, but doing it in a more rational way. There have been attempts, and very unsuccessful attempts in my view, to really just take a hatchet to healthcare spending by the government. Various times they all sit down and they say, we're going to just take this much off the top of the healthcare system and then leave it to the rest of the system, the doctors, the nurses, the patients, the hospitals, et cetera, to figure out how to work with less money, but not really address some of the underlying reasons that were driving healthcare costs up and up. The way that they are going about it is really to work with hospitals, doctors, and patients to start changing the delivery systems of healthcare so that they have more prevention in the front end, they have less redundancy, and hopefully better systems of delivering care. But all of that is yet to come. And that's where I think all of us are most concerned about how this plays out over the next few years. So a couple of things in terms of, as you know, this law was passed in 2010, but its major provisions are still being implemented, and most of them don't go into effect until 2014. But even today, beginning in 2010, after the president signed the law, there are programs in every state available to people with pre-existing conditions, including HIV/AIDS, who've been unable to buy private insurance, to sign up for a program called the Pre-Existing Condition Insurance Program. And in Washington, we have to have an acronym for everything, so these are known as the PSIP programs. They are in every state. Some of them are run by the federal government, some by the states, but every state has them. And people are eligible if they have a pre-existing condition and if they have been unable to buy health insurance. So they have to have at least attempted to buy private health insurance. That PSIP program has about 50,000 people enrolled in it across the country. Some states have larger numbers, but it hasn't been an extraordinarily popular program, not because of the structure, the fact that it would cover people with pre-existing conditions, but because the costs are fairly high. The PSIP premiums are aimed at the market average, so they can't be charged a lot more than somebody who's healthy, but the market average in our current system is often too high for most people to pay the whole premium themselves. So In some cases, tremendously helpful program, particularly people who have very high health care costs, because for them, even a high premium is well within what they need to spend on, much less than what they would spend if they didn't have it. So 50,000 people. And when it comes to HIV/AIDS, that has been a very important program. The Medicare program, which covers people who are over the age of 65, but also people with disabilities, including people with HIV/AIDS in many cases, has also been changed so that the prescription drug benefit, which was passed in 2003 and has a significant hole in the middle that they call the donut hole, that has begun to shrink so that people are getting lower costs for the drugs they buy while they're in the donut hole. And in particular, it's important to note that in the ADAP program, the costs count towards the Medicare out-of-pocket limit. So people with high costs through ADAP actually get lower costs through the Medicare program already. Children with pre-existing conditions can't be denied private health insurance. Insurers are very limited in their use of annual limits on benefits, which often cut off coverage right at the time somebody gets sick or very sick. And the federal government has begun to invest in both in prevention, but also in the federally qualified health centers, also many places known as community health centers, so that they're both supporting the ones that exist, but beginning to give states and communities money to build more facilities to help people who either have no insurance or have limited ability to pay for care. In 2014, we'll see these fairly major provisions kick in, and I'll just quickly tick them off here. Private insurers throughout the country will no longer be able to deny coverage to somebody based on their medical condition. So if somebody has anything from asthma to cancer to HIV/AIDS, insurers would have to accept them as a customer and could not charge them more than a healthy customer. That's a tremendous change in the health insurance market, as you can imagine. The annual limits that I mentioned earlier will be gone, but so will lifetime limits. So people won't be able to buy a policy that suddenly cuts off when their illness is at its most expensive and most critical stage. Insurance companies won't be able to charge women higher premiums than men. They won't be able to charge small insurance companies higher premiums than small companies and their employees more than they charge large companies and their employees. And then people with income between 133% of poverty, which right now is about $18,000 a year, and 400% of poverty will be eligible to buy health insurance in what are called state insurance exchanges. And they will receive fairly significant tax credits to offset much of the cost of that insurance. And then finally, for people with incomes below 133% of poverty, below that $18,000 line, the Medicaid program is going to be expanded to provide coverage in states for people, including single adults, as well as families with children. We're going to talk a lot more about that, as you can imagine, in the coming discussion. Finally, the one provision of the Medicaid law, and I think our next speaker will probably be touching on this in more detail, so I won't go into detail, but you heard the Supreme Court upheld the Affordable Care Act, but one thing they said was that the Medicaid expansion, which was pretty much mandatory for states to adopt it, has now been more of an optional expansion that states can or cannot decide to adopt. So we have a lot more debate and a lot more fighting, frankly, to go in the years to come. All this creates, in my opinion, a great deal of hope for people living with HIV and AIDS, a great deal of support for their families, for their caregivers, for their physicians, and for their communities. But like any big change, it creates a lot of uncertainty. And that's why I think today's discussions, where not only will we hear from the experts, but each of you will have the opportunity to ask questions and get answers to things that you're thinking about as you look at your practice, as you look at your patients, and you look into the future. We have some of the leading experts on HIV/AIDS policy, both from the private sector and the public sector, so I know we're going to have a very informative discussion.